Okay, welcome, ladies and gentlemen. Another MSMA educational series. Topic is artificial intelligence in healthcare sector or modern medicine, whichever. The intelligence is an ability to learn lessons. It's an ability to apply those lessons in a real life situation. It could be an emergency or it could be a non-emergency. Therefore, intelligence is the higher order function of the human brain, unique to the human brain. With this intelligence, the human race mastered the planet for centuries. I want to give you a small story. I grew up in a farm in South India, and we had a lot of problem from fox stealing away our lamb. So my father used to tell me, fox has the nearest intelligence like a human being, and it used to be a threat. Now I'm telling my children who are junior doctors that there's a new threat to the human intelligence, and we call it artificial intelligence from computer world. So far, I have read there's more than 100 companies working on this artificial intelligence in various fields, including health sector. It's coming in a big way, and someone speculated it will knock off 40% of jobs from people. I'm not sure. Is that true, Rajesh? We have we have an expert from New York to tell us whether it's true or not true. Rajesh is the assistant professor of mathematical science and data science in Current Institute at the New York University. He did his basic degree and master degree in Stanford University in USA, and his PhD in Princeton University. One of his area interested in is machine learning for healthcare sector. Rajesh, the floor is yours. Tell us what we should know about in the health sector in artificial intelligence. Thank you.
Thank you, and thank you all for having me. So I wanted to start out with talking about what artificial intelligence is. And I thought about this for a few minutes, and then I was like, maybe I should go back to a textbook and see how people define it, because it's a little bit ill-defined. And so the best one that I could come up with was we define AI as the study of agents that receive percepts, so they see what's going on in their environment, and they perform actions. And it's like quite generic and quite vague, because as we'll see, like in a particular example in a second, it's pretty hard to nail this down exactly, even in terms of like what a human intelligence might be defined as. But if we wanted to imagine ourselves back in 1970, and there are like a bunch of games that only humans can play. Like an example of that would be chess, where it's complex reasoning. There's a specific environment at play. You have to make decisions for some outcome that's not immediately obvious. And people are like, well, if you solve chess, you've built an AI, and then you're going to learn how to do reasoning, and it'll be really cool. But if we move to the 2020s, there's automated chess everywhere. It's on your phone, it's on a computer, and it's better than almost all humans. But people would still maybe be like, I don't know if we did AI. I don't know if this is what we call artificial intelligence. And that's really because the definition is a moving target. There are tasks that are considered to be quite hard, and they are hard in the sense of we don't know how to program a computer explicitly how to do it. But then it turns out if you have a little bit more compute and you have a little bit of access to an environment that you can play in, then you can do a pretty good job at these things. And the categorization that you'll see if you're looking at the general literature would be something about specific task intelligence, where playing chess would be a very, very specific task intelligence. There might be slightly more general notions of that. Instead of playing chess, maybe you play chess and checkers. And then on the other hand, you'll hear something like general intelligence. And general intelligence was the thing that I was trying to define one slide earlier, and when I got that definition from a textbook, where it's like not just that like you can be in a specific environment and take actions for a specific goal. It's that you're flexible to work across different environments. And sometimes even the notion of like, how does the goal come up or who gives you the goal is part of the notion of general intelligence. And most of the things that, when we talk about AI are going to be specific task intelligence. There is a hope to do this kind of general intelligence, but I'd say that, as of now, we're a bit far from that. So what's with all the hype in artificial intelligence? Well, first off, there exist algorithms that can solve games. And before, in the 1980s, 1990s, you'd have a specific algorithm. You'd have a computer that learned how to play chess with a bunch of human assistants. And now we've gotten further. You can have an AI that can learn how to play any of these games, like chess, shogi, Go, Atari, without having to program some human knowledge inside of it. The way they work is basically they have access to the game's simulations, so they know like what moves are possible and they can play both sides. And by like being able to simulate the state over and over again, for a video game, there's a computer that provides the environment. By being able to simulate these over and over again, they can figure out the right approaches to take to win the game. And what was special about it is that it was like a little bit more general than what we had before. Before, you might see an AI for chess. A couple of years ago, there was a big announcement that there is an AI for Go and it outperforms humans. But now there are like AIs that can do all these at once. So it's a little bit more general. There are also different things that would fall under AI that are pretty exciting. Recently, there was a big advancement in protein folding where we could predict the structure of a folded protein with much higher fidelity than we could before. And this used AI technologies. Another fun one is like people are working on fashion improvement where you give like an image of your outfit, and you want to see like what changes can you make to it that are minimal visually, but would make it be perceived as fashionable from a large set of people. And these are like algorithmic motions along this curve. Another example is like, if we think about like how to do something like generate voice, if we want to say like, take a book, convert it into voice, it's not obvious how you'd program a computer how to do that. And this is another case where AI has come to play a role. If you have like the Google Assistant on your phone, all that voice is not generated from a person like stitching together the recordings. It's actually generated from a computer algorithm that has learned how to take text and translate it into voice. One of my favorite ones is actually one for tracking. Like you can imagine there are a lot of causes in the world. So this example could be like an ecological cause. We want to track a certain kind of bird. We want to track like, tigers or elephants as well too. And you set up cameras in the wild. And this is collecting like continuous data because like anytime an animal walks by, you'll have a chance to see something, but most of the time there's not an animal there. To have a human like figure out what's going on is very, very time consuming. They could maybe watch this video at 2 times the speed or 4 times the speed and figure out the animals in it. But like having an AI that could automatically figure out what's going on can give us better sensors from which we can characterize the world. There's a subset of AI, and that's mostly what like AI for healthcare is based on. It's called machine learning. Machine learning is really about getting computers to do things that they weren't explicitly programmed for based on experience through data. And if I draw a picture of it, it would be something very simple. It would be like, here's the data that you have. Here's a machine learning algorithm. So like, unlike a traditional algorithm, which is explicitly programmed to do a task, like if I have a bunch of numbers and I want to sort them, I can write some code that will help me sort them. But here is like an algorithm that learns how to do things based on the experience that it gets. And one of those things might be to classify the data as being gray or being orange. And if I talk about this mathematically, it would be like a conditional. You want to know about the probability of something given that you have knowledge of something else. And there are lots of different kinds of machine learning. And if you look at the health literature, you'll see these in various forms. One of it is supervised learning, where you want to predict an output from an input. You might think about it as like predicting whether someone has diabetic retinopathy from a retinal image. Others might be finding hidden structure. Sometimes you get like a really, really complicated measurement. It's very, very large, but like what's actually important is like much, much smaller, and you can characterize it. You might think of something like population structure in genomics as something that is like hidden. You don't know exactly what the population is, but is actually in the data. We talked a little bit about generation, which is making simulations that look real. So if I can simulate voice that sounds like a real person, in healthcare, it might be like molecule generation or protein design. And reinforcement learning is probably the most general of the setups, where you have some agents that can take actions, and the actions are based on the environment. It might be like the legal moves you can make in a chess game. It might be the games you can play with a video game. It also could be the actions you can take while you're treating a patient in the ICU by giving different kinds of medications or like mechanical support. And there's some reward, and what this reward is difficult often in many environments to state. So at a very high level picture, how does machine learning work? Well, machine learning sets up this, question of like a model family. And this new here is a parameter. So you can imagine this big circle is like a bunch of models that we could potentially specify. And so my computer has access to all of these models. And the goal of machine learning is to take, maybe one of the models that we have and move it so that it reaches some point of high utility. And that sounds relatively simple. High utility could be like the high reward I was talking about. It could be some notion of quality of generation of the samples. It could also be, do you just predict well? But like the real challenge in machine learning is kind of this, and this is maybe the fundamental challenge when working with data. So we'd like to have high utility with respect to a distribution. So like all possible, places where we can collect the data. What we observe rather is a finite sample of that data. It means that, there's a giant population of patients, you only get to observe like 10 of them. Then what happens in between, say like, you have one patient that has some value like 10 and another patient that has value 12. And you're like, what happens between 10 and 12? That actually is only going to be made clear through assumptions. And like what those assumptions are what are encoded inside of these like model families. And the other way that you can encode things is data, because like if I had like a point at 10 and a point at 12, if somebody gives me 11, I know what's going on somewhat in between. If somebody gives me 10.5, 11.5, and I'll start learning more and more. So like the key ingredients to make machine learning work, because it's underspecified, are assumptions and data. And you can check the value, right? The way you check the value is you collect a little bit more data and you see how well you perform. So now I want to jump into a little bit of AI in healthcare. First off, there have been a lot of successes for AI for health, and these successes, I'll air quote them for now, meaning that we can talk about what they actually are in a fine-grained detail in terms of their translation and the question answer point. But there are papers that look at chest radiographs and classify what's going on. They might classify pneumonia, cardiomegaly. There are fun examples of people taking retinal images and predicting what the person's BMI is. There are also examples in pathology for prostate cancer, more ophthalmology examples, predictive examples, and we'll get into this more. And there's a lot going on. There are a lot of things, but the way that things are going on is not necessarily homogeneous. And like organizing the types of problems is really helpful to understand like what's going on, what's difficult, where the value is. So if we think about just like tasks that have like some kind of like label associated with them, like figuring out if like a bone is fractured or not in an X-ray, these are like perceptual problems. And these perceptual problems, you can take like the signal that you collect and you can read off the answer from that perceptual input that you've taken. On the other hand, there are causal problems where you might ask a question like, if I do this intervention, if I give this medication to someone, if I perform this procedure, what would be the effect relative to if you didn't? And the challenge really is that, as you move from one end of the spectrum to the other, noise gets higher and assumptions need to be stronger. And we can look at that a bit pictorially. So perceptual problems are where like the largest successes in AI have been. One kind of perceptual problem is object detection. Another perceptual problem would be machine translation, where we want to translate from one language to the other. But these exist in healthcare everywhere. where like an example might be classifying an arrhythmia in an ECG. It could be identifying what's going on in a chest X-ray. It could also be in pathology, where you want to see what's going on in like different locations of like a biopsy you've taken. And if I pictorially describe this problem so you can understand what's going on, you can imagine there are different measurement streams that you can collect about a person, like measurement A, measurement B, measurement C. And these kinds of perceptual problems are ones where the thing that you're collecting in time actually tells you what the label is, like what you're actually, it contains what you're looking for. If you look at a electrocardiogram, you can read off atrial fibrillation from that electrocardiogram. There's not some other data, or there's not some time in the future that you need to wait for it. The next class of problems, and this is probably one of my favorite classes, maybe my favorite class of problems that I like, are estimation problems. And estimation problems are, we want to take one kind of measurement and say something that's typically perceived in another kind of measurement. The canonical example of this is taking someone's electrocardiogram and trying to predict their ejection fraction from their electrocardiogram. Typically, you get a direct measure of ejection fraction from an echocardiogram, or maybe like even a stronger measurement for like a gold standard. But like the fact that you can take a measurement that is less invasive, it's easier to collect electrocardiogram, and say what's going on about a more invasive one, and you do it through machine learning, is exciting for me, because it opens new doors for other measurements that we have and new ways that we can use them. Another example, I don't know what the practical implications of this one are. If you take somebody's like the image of their retina, you can predict their body mass index. I'm not sure. It's like scientifically interesting, maybe, that you can do that, but it doesn't necessarily meet like the criteria, I'd say, of like the problems that would have like the translational impact, where it's probably much easier to directly measure someone's BMI than to take an image of their retina and compute their BMI. They're predictive problems, and these are the kinds of things that we think of traditionally about when we think about like AI or machine learning for the future. The example that like pervades the clinical literature is one for septic shock, where so you have patients who are in the ICU. If you know that septic shock is going to happen earlier, you might be able to do something about it. So people, and there's like, I'd say at least tens, maybe even hundreds of papers that are building these kinds of models, where the goal is to take the measurements that you have at a certain time, and maybe the past history of those measurements as well, and try to make a prediction about something that will happen in the future. So will the person have septic shock in the next 72 hours? And finally, I have causation, and causation is kind of like the prediction problem, except there are these like unobserved variables, or hard, or maybe observed but need to be specified by an expert, variables called confounders, which explain the relationship between the inputs, like the treatments in this case, and the outcomes that occur later in time. And the reason, like unlike the previous slides where I had examples of like citations, the reason I don't have any citations here is because, one, this is a very, very hard problem, and two, like the AI approaches to causation are still in their infancy. But the key reason that, now we'll come back to this one more time again, but the key reason that like AI maybe is specialized or more difficult in healthcare is just that a lot of the data in healthcare is difficult. You have patients visiting infrequently. They also visit for reasons, meaning that the data is collected because a doctor has some insight about that patient. So a lot of the things that we like to look at in terms of like, hey, if the data is missing, it's okay, as long as it's not missing through a reason. Also, a lot of data gets hidden. This is especially a problem in the United States, where it's very hard to track a patient over very long periods of time because they can move, they can go to a different hospital. They're confounders, things that like haven't been accounted for, that both are responsible for the exposure or treatment and also modify the outcome. Another issue is sampling bias. We get to see like patients from one specific population, even if then we condition on having follow-up, it's a really funky population. And we don't know if those results will really move to the actual population that we care about. And some of what my lab works on is really like mathematics and machine learning to deal with these issues. Methods for missing data, causal inference, explainability. Like if we have like a predictive model that's predicting ejection fraction from the electrocardiogram, you could ask the question like, what's important in the electrocardiogram to make such a prediction? And then also probabilistic modeling, where we want to actually build models or build AI systems that take into account uncertainty as like a first principle in a building way. And so that was the high level picture. And I wanted to give an example of something that's like AI-ish that we did here during the COVID-19 pandemic, which maybe will make a lot of the issues and potential clear. And at the very end, I'll have like a couple more slides on, why things are slow and, what are potential avenues where we could do things on. So this is a little bit dated, but like at least in the US, the COVID-19 pandemic has been responsible for just a ton of deaths. And what me be doing AI for healthcare, the question really is like, how do we make AI models to help with COVID-19? Well, first off, we need the data to be available. For a lot of tasks that I get approached by, that clinicians approach me with, there's just like not enough data to answer a question like that. Second, we want something where knowledge of the prediction can inform decisions. So, these are maybe like data is not available for questions that clinicians come up with. Questions that computer scientists come up with often are the second one, where we can like predict something and it's really cool. And then you might talk to like a clinical expert and they're like, we would do nothing with this. And finally, the last thing you'd want clinical leaders to support deployment, because kind of like you can build something cool, it can be prospectively validated, but you do need people on the ground who actually care and will like push their teams to use it in the appropriate way. Otherwise, like you can build it into the system and nothing will really happen. Early in the pandemic, at least in New York City, there was there's a bunch of shortage of testing. And so people, when they would go to the hospital, would have to wait quite a long time to figure out if they actually had COVID-19. And so the question was like, we want to predict a case from just like easy to collect measurements that are taken before the test is done. But if we look at the time duration of the pandemic, by the time that there was enough data maybe to do this, testing was more available. And so it's not much value in actually doing this. Instead, we could try to predict adverse events, and there are adverse event models that are built inside of systems. But the problem with, at least early in the pandemic in New York City, for an adverse event model was that when you're at capacity, it's hard to take an action. Like if you tell somebody this person is highly likely to have an adverse event in 48 hours, and like all your like higher levels of care are completely full, there's not much you can do with that information because you want to know about the people who are immediately having the adverse event right now. So instead, you can reverse the problem, which is just a semantic reversal of predicting no adverse event, where here you can free up space on your action. So you can take somebody from the ICU, you can move them down to lower care. Somebody who's on like the general floor, you might say you'd be ready to discharge. And we tried to do this. We took data from March 3rd to April 26th. I added 2020 because this used to be of the most recent March 3rd to April 26th. And we had about 3,000 plus patients. And the kinds of adverse events we're looking for were ICU transfer, death, representation to the emergency department, going to hospice, or significant oxygen support. And we were collecting a small range of inputs over like a fixed time period, and we wanted to predict adverse events over a little bit of a longer time period. And I can tell you more precisely in a bit. And we had like a bunch of lab values. So the standard lab values that you'd get in like basic metabolic panels, vitals, O2 rate, and like structural things that we thought might be important, like days since admission or demographics. And if you build a model to predict adverse events or no adverse event, you can do quite well. And so these curves are basically the best they can be when this curve is like up and to the left, and this curve is flattened across. They're numbers I could give you, but I wanted to just say that it's still not clear at this point, like, do we have a good model? And I'll try to make that a bit more precise when we go into the details. The first real major detail is that there's a lot of changes in treatment and understanding. And if you look like in March, people might be prescribing one kind of medication. If you look in June, people might be prescribing another kind of medication. And just looking at hydroxychloroquine, which in the US went through like quite the story, you can see like the actual like evidence over time where like by June the FDA is like, do not do this, while in March the FDA is like, hey, let's do this, and people were doing it. But the problem with machine learning when you have like data that looks like this is that machine learning typically assumes that the data comes from the same distribution. And so that like if I see a new person in the future, their risk of an adverse event will look similar to the person that is in the past. But as like knowledge is changing over time, then it's not the case. And so we need to check the data. Like the data, like here, like, I like to do AI and I like to build like big predictive models, but I get concerned when I hear like the data is like as messy as it was last year during the start of the pandemic. And, this is my graduate student. I drew him here, and he has these tiers because he has like this little magnifying glass, and there's like so many different kinds of data that are in the health record. And he's like, how do I know if it's good or not? And like, he needs to talk to a lot of people. He might need to talk to a clinician. Not only the clinician, he needs to talk to people who run the IT at the hospital, because they can tell you how like the data gets, passed from one set to the other. And it's a lot of work. And there's time pressure going on as well here too, because, during the pandemic, getting something out as early as possible to provide some kind of guidance that's grounded in data would be the most helpful. And so here we, took like a technical approach that like fuses things from statistics with things in AI. And the basic idea is like, we wanted to limit ourselves to inputs that provide additional information about the thing that we're trying to predict. And so this is math notation for additional information. So if we have a bunch of inputs, these are x minus j are the inputs except for the jth input. It's like every input except for what could be like neutrophil count. And xj could be the neutrophil count, and y is like the adverse or no adverse event distinction. And this mathematical notation says, there is no extra value from the neutrophil count to predict no adverse event, given everything else about the patient. So given everything else that we've listed of those 65 values, the other 64 of them. The basic idea to do this would be to simulate synthetic features. So things that look like your real data, but actually have no relationship with the thing that you're predicting. So we want to create like neutrophil counts that look like human neutrophil counts, but have no relationship with whether or not somebody has an adverse event. And this is where like simulation, the kinds of generation things I talked about earlier, come into play, where before we were trying to do like complex generation of generating audio, but here is also a generation problem where we want to generate neutrophil counts that look plausible given everything we know about the person. And to do that, we would build like models to do it. And finally, once we have these, data sets where there are no relationships, so we have original data, there might or may not be a relationship. There are fake data sets that have no relationship. And we compare test statistics on these simulations to the real. And this is like a standard hypothesis test would work. The hypothesis tests that you would see in like most clinical papers are based on this, though they may be based on taking these replications to a very large number and using some mathematical properties to turn the computational problem into a simple math problem. So the two questions you have when you're trying to do this is, first, how do you make these samples? And two, like, what makes a good comparison? For the first one, we can just use the ideas from AI, where we'll train a deep probabilistic regression, which tries to simulate what each input would look like given knowledge of the rest. And you can do this for all features at once using something called a deep generative model. These deep generative models are exactly the same technology that are used inside of Google's Google Voice to translate from text to voice, and inside of Google's Assistant. And the test statistics, this is a question of like, how do you know what to look for? So if I give you like two different data sets and I'm like, what's important in terms of like making a prediction, like, does that thing actually provide information? It can be a quite complicated thing to ask for, because it could be that thing. It could be neutrophil count in concert with a bunch of other variables that matter. It could be the It could be the logarithm of the neutrophil count that's very quietly associated. And this is where like AI comes into role. The kind of big jump in AI that's been made in the last 10 years is that most AI before, say, 2010 heavily focused on having a human come up with all these inputs and then doing something with it. But now, like, the technology has progressed where the goal is just give it the inputs and let it figure out these combinations or what functions of it are important to make a prediction. And once we did this, so we took conditional randomization testing, which is a statistical tool. Then we took in like machine learning predictive models, and we reduced the features that we had, like the inputs that we had, from 65 to 16. And reductions in features make it easier to audit because there's just less stuff to go through. And what do I mean by audit? Like, why do we talk about auditing our inputs? So this is an example, and this is a real histogram of the body mass index of people in our population. And there are a whole lot of people. In fact, the mode of the distribution is at 0. So most, like, if you were to guess at once from the mode, like, what is their BMI, you'd say their BMI is 0. And that's not real. So something is going on in the data. And basically, it's heavily missing. And this heavily missing aspect is peculiar because we're like, why is it missing? And not only was it heavily missing, my student found that like it being missing is like very, very indicative of having an adverse event, sort of not having no adverse event. And this missingness is like, like when we talk to doctors, or I should say my student talked to doctors and was like, hey, are you just not weighing really sick people? Because if you don't weigh really sick people, then people who don't have BMI measurements are the ones that we're going to be more likely to have an adverse event. But it turns out not to be the case. They're bed scales, bed scales weigh people. And like, it really turned out to be like a nitty gritty issue in terms of like how that data gets translated to the point at which the model can have access. So you had to talk to somebody who does IT and who tells you like, hey, these are the kinds of BMIs that appear in the health record with enough time to do something with. Here are the kinds of BMIs that might appear in the health record on like a few months time scale when there's some reconciliation that happens between, say, the bed scale collected data and the data that gets manually entered into a flow chart. And you have to do this for each input because you're very unsure. You don't know what's going on. The care practices are highly variable around this time. And the fact that it was fewer made it easier for the team. And this is like the broader team who did this. Our part of this was like, hey, here's some data, build some model. Should we like believe this model? But then you're left with something else. You need to deploy and convey a model. And so like, what kind of model do you want to deploy and convey? You want one that's like easy to understand. And this is not necessarily at the bedside easy to understand, but like in terms of deployment, you want to make sure that like it's relatively easy to understand just because you want people to be on board with it. And you want to make sure they're not weird issues like what we just saw with the body mass index. You want it also easy to deploy. And this is more of a computer science consideration where all the data that you think that might be available is not actually available at the time at which it's important. Like they might have to process through several systems before it can be read back. And by that time, if it's like an outpatient visit, the patient could already be gone. And at this point, we also wanted something to visualize because most doctors themselves didn't have a lot of prior knowledge on what's going on because it's a novel disease. And so these kinds of visualizations can be useful for doctors to check and grow their understanding. And so the thing that we settled on was like, we had like an AI, which is gradient boosting, or you can call it a traditional like statistical model. But we wanted to go even simpler than that. So we were like, if we can make an accurate linear model with a few inputs, then we would meet the criteria that we've laid out between understanding, deploying, and visualization. And partly to how you take something that's nonlinear and complex and reduce it to something that's linear, well, you have to test and see if there are things nonlinear happening inside of it. So again, this is kind of a bit of a manual process where like math produces all these curves and you can actually like look and see like, hey, this is not going down as a line or going up as a line. And so it looks a little bit nonlinear. And this is for the maximum O2 rate in the past 12 hours. All our features were collected over the previous 12 hours. And to do this, you need to actually like adjust your model a little bit. The second thing that you see is there are also outliers. There are a lot of people who have mass between 0 and 7.5. There are people who have plenty of mass at 15. And when you have outliers and you want to reduce like something that's complicated, like a tree, which can take decisions and like say like greater than 15 means something less than 15, to a linear model, which will take like a number and multiply it by a large input, then you're going to have to be careful. And so the thing that was come up with was to, rather than look at the raw inputs, we want to look at the percentile that of which the person falls into. And you can do this and you'll get like very similar performance with only 14 variables. So we took what was like an off-the-shelf like machine learning package. We fit a model. Then we used like tools in modern AI to take that model and reduce it to something much smaller so we could check the data. Then once we reduced it to something smaller where the data has been checked, we wanted to simplify further to make visualizations, and we were able to simplify without much of a loss in performance. So again, these curves are good if they're up and to the left, and this curve is good if it's high. And you can see that the red thing, which is like the reduced version that we came up with, is not too much lower than the blue thing, which takes into account like all the information that's available. And it's relatively easy to visualize. This was built into the electronic health record. And we were able to like build something where there are a bunch of patients. There are scores associated with them. High scores meaning that you have like a high risk of adverse event within 96 hours, and low scores meaning that that you don't. And it was prospectively validated. And here are their actual numbers. If we're looking at area under the precision recall curve, you get something that's quite high. It's 0.908. And if we have the receiver operating curve, which is the true positive rate versus the false positive rate, it's 0.868. It's over 445 patients. But like, I want to say at this point, like deployment is not magic. You know, even though it's in the health record and like it's prospectively validated, meaning that it makes the correct classifications well beforehand, there are lots of decisions left. First is that like adverse events went down over time because people maybe stopped trying to do various things, or people started going to the hospital a little bit earlier. Next is that linearity can lead to oddities where like having a high temperature means that you're going to be much more likely to have an adverse event. But if you're hypothermic, you're not going to be like much less more likely to have an adverse event than somebody with a normal temperature. And in silent deployment, the correct labels, if we take a 90% positive predictive value threshold, which is here, which recalls quite a few of the patients, we're an average of 1 day earlier than actually were documented in the health record for, you know, a change in care. But like still here, I push and say that we need some kind of research and effectiveness where, you know, we can build a good predictive model and we can know what's happening, but that predictive model has to integrate with care. And, you know, people in this case can influence each other based on models. So like if we think about like running a randomized trial with a model and the model is a treatment, there are a bunch of indirect effects that need to be accounted for. People can also learn to mimic the model, where if they see a model a bunch of times, they can not actually ignore they can actually, you know, forget about what the model's output is and say like, I learned how to do this, which is not necessarily a bad thing. People can also ignore the model where like when you give somebody a medication or a placebo, there's some notion of compliance. And so you know that the pill is swallowed and then like physiology will take over. But like whether like a clinician or somebody who's making the decision is actually using the model in a reasonable way is hard to say without going one step further and establishing like a protocol from which the model on how the model should be used. And people can also misinterpret models. Like when you provide people with visualizations, there are a bunch of studies that show that these like AI-based visualizations can make people actually worse at doing their job than without them, or just providing a straight prediction. And like part of like, you know, the question is like some of what we described was manual. There is some AI going on. Like when you had the data set and it was reduced, there's AI going on that would translate from what I call, you know, a bunch of features to a label. But, you know, where's the AI in telling you that like BMI being 0 is not a plausible thing? And like from a computer science standpoint, we should expect that that should not be possible because literally it's a piece of computer code and it's like a data matrix and there's no structured information or no like knowledge that's outside of it. And so we can give you an idea of like kind of like the level of which these approaches are. But the same issues that we have are translated to other less time sensitive models where like there's weird stuff going on in the data. We don't exactly know what we're going to do. We don't know why these like biases are there. And like, I get back to this point, like, why isn't AI everywhere in medicine right now? Like AI really has pervaded a lot of our day-to-day lives. Every Google search you make is powered by like AI. When you look and do like Google Translate, also powered by AI. If you use Facebook, a lot of what's on Facebook, what you see in your newsfeed is curated by AI. But like, what's going on in medicine? Like, there are a few success cases. So like that model was deployed. There are things for like diabetic retinopathy that have been approved. But like, why isn't AI everywhere in medicine right now? And I go back to this thing that I said earlier, is that the data is very, very difficult, where like, people visit the doctor for specific reasons. We lose people to follow up. There are confounders. Populations can look very different from the ones that we'd like to make a prediction on versus the ones that we have access to. And why is this very, very hard with AI? And why are like simpler methods a bit more robust to it? Well, AI is just very, very good at finding like patterns in the data. And if these patterns are what I call spurious due to changes in population sampling or due to confounding, the AI will find that and it will make use of it, and it will do a great job at predicting what's going on. The example that people talk about are like for chest x-rays, there's a chest x-ray classifier that could classify things like pneumonia. But we found that like if you're looking at like how the chest x-ray classifier is working, it's making use of like information that is like that's not tied to the physiology. It might be like text in the left corner. It might be the scanner type that people go to, like whether the scanner was portable or not. It also could be like tokens that are placed to do alignment. All this information is present, and the computer really has no like a priori reason to say like, don't use that, ignore that. It's not really worthwhile. Rather, like a human would be like, well, I know that if I'm going to make like a diagnosis, I'm going to look at what's going on inside of the body. I don't need to look at the part of the X-ray that's outside of the body. And that kind of knowledge is not anywhere inside of these AI systems. But still, there's lots of potential. There's just a ton of things that can be done if we can get the data right. And also, there are a huge number of technological hurdles that we'll need to cross as well too, like personalized advice during surgery. Like if somebody's doing robotic surgery, you can imagine that the data being collected through like the video could be processed at the same time and indexed with like a database of other patients who have actually also had this surgery to provide personalized guidance during that surgery. You can have risk models for chronic diseases. Treatment guidelines for cardiovascular disease are based on like 10-year risk of events, but like accurately quantifying the 10-year risk of having an event is quite hard. Mobile tracking and characterization of diseases is another one. An example I think about is for Parkinson's disease, where you can collect a lot of data about like how somebody is like moving and how their like fine motor skill is using a mobile device. And that data is like much more fine-grained than something that you would have to classify a Parkinson's disease patient like UPDRS. And why is it useful? Well, it's useful for a couple of reasons. One, like if you're designing a new medication, you have like more outputs that you could target. And two, like these kinds of AI for characterizing like subtypes, like, Parkinson's may have like different kinds of subtypes that have different trajectories, could also reveal a little bit more about the disease. Treatment planning for cancer is another one where AI could have a big role. Some of them are very concrete, where you're trying to do like if you're like a radiation oncologist, you might want to have a specific plan of like how you deliver your doses to minimize damage to the tissue that's surrounding the tumor. It could be more general, like do you give somebody radiotherapy or radiotherapy and chemotherapy? What's their prediction to completion? So they might be eligible for some kind of immunotherapy. And there are just a ton more. And so like, even though I said some negative stuff about the data, I wanted to end on this positive note.
Right. Thank you, Rajesh. There's so much involved mathematically before you bring your application into the real world in the hospitals. We realize that. Have you worked with the doctors in the clinical setting? If you have, tell us your experience.
Yeah, so the COVID model was one, and that was a giant team. Like I have to say that like there was the IT team and like the hospital team who then contacted me because they have the ability to build models and they're quite good. They're quite good at it. But then they worry. They're like, hey, you know, our data is changing. Are we doing this the right way? And they want to use it on patients immediately. And so then they contacted me. And that was a very pleasant experience because everybody had a singular goal. Like I've never seen anything move so quickly because both the doctors were like, we don't know what's happening. The people in the data wanted to like make use of the giant amount of data that's being collected. And then we on the other side were like, hey, this is like an issue that's touching everybody. So everybody was motivated. There are other places where there are like, you know, I'd say like the troubling places are like when the question is like not necessarily precise. And what I mean by that is like sometimes I get asked questions and I'm like, you know, the data is very, very small, or it could be that like it's impossible to answer without making assumptions that are not encoded somewhere. So it might be something like, hey, we give everybody a treatment range from like 1 to 10. What would a treatment 20 be? And like that's never observed in your data. And so those kinds of things need knowledge that's outside of your data. And that's where like what I call prior knowledge comes in. I have collaborations with cardiologists. I have collaborations with a pathologist who does a lot of hematology and oncology. I collaborate a little bit starting with some neurologists now. And overall, I would say that the biggest barrier is actually getting the language correct so we can settle on a problem that is both solvable and interesting to solve. Because like certain questions are also like maybe the other spectrum where like I could tell my PhD student, hey, you know, look into this, and it might take them 5 days to solve it. And so like the right level of question, and that takes like communication, but establishing the language for that communication is one of the hardest things.
Thank you. I have worked with the robotic tool in treating prostate. So I have some limited experience. And robot in surgery is always, we say, it's a master-slave relationship. So you just instruct your robot to do what, and then you can stop when you don't want it. So I'm happy with that. But then we read about the AI coming with super intelligence, super than human beings. That may be a threat. Do you think it's going to happen?
I think if you could build me a great simulator of patients, like if you could tell me, like if you had like a huge understanding of human physiology that could be encoded in the simulator, then I think the technology right now would tell you, like, yes, we can do this. Like, you know, you could like, you know, just like you play a game with super intelligence, you could do the same thing here. But the difficulty is really in that, where like you have some examples of what's going on, but you don't have like the large amount of data that's needed to power the things. So it's possible, but I think like the translation of like, how do we learn from less data, or how do we make computers learn with less data, is really the bottleneck in making that happen.
Okay, thanks. So we don't have to worry at this stage then, at least in our generation, yeah?
Yeah. Maybe my generation you might worry, but
all right. I'm going to leave it to the floor to ask questions. Please enter in the chat box, and I'll call you one by one. Please put it in the chat box. And when you answer, please unmute and answer. And there is a comment there is a question from Shiv Kumar Pandian. Are you there? Shiv Kumar Pandian?
Yes, Raju, I'm here.
What's your question?
I wanted to congratulate you for organizing this excellent webinar. I want to congratulate Rajesh for giving us this very thought-provoking, interesting talk.
Yeah.
So I'm just curious to know what his future projects in healthcare is going to be. Any specific projects that's cooking already, or anything that's going to be explosive in the coming days?
Explosive is too bold, maybe, but there are things that I'm interested in. One thing that I'm interested in is like these kinds of estimation problems that I talked about, where we take like a high dimensional signal, like an electrocardiogram, and we use it for something else. So we might use it to track like a measurement that typically won't be measured off of that, like lung function or things related to like basic metabolic functioning. Another class of questions that are similar to that are where you collect a bunch of information about somebody's blood cells. So you can take like individual single cell measurements. You might get like hemoglobin and like volume. And you want to know, like, given that I have this entire distribution, is there something that I can say about a person's health? So the kinds of questions that really interest me, at least from the AI perspective, are like, AI is really great at working with these high dimensional signals. Can we use them for other tasks beyond which they are used for traditionally in medicine?
Excellent. Yeah.
Thank you.
Thank you.
There
Best
is
wishes
a
for you.
question from Elil Anand.
Okay. Hello. It was a very, very interesting talk. In fact, I'm a psychiatrist. We were having a debate with my colleagues, and I believe certain specialties like radiology, where you have some sort of quantitative data, it's easier for AI. And in fact, we are joking, at least our jobs are safe in a way. In psychiatrists, we follow what we call a bit of a biopsychosocial model. So where many of our data are more qualitative than quantitative. Do you envisage that, certain specialties there will be a role in AI, and probably in specialties we don't have any role at all?
So I always have to say in psychiatry, there's something that I am interested in. Well, I'm trying to get a data set in order to understand like which patients will be resistant to treatment for depression. Because like the way it's, people might go through a bunch of treatments, it takes some time, but if you can know from data up front and make a prediction, then you could do something about it. But the thing that you said that's most interesting is like, where does that data come from? And so in radiology, that data is digitized and it's directly available. And it also is of this high dimensional form. So like part of like the things that, I'm interested in are like collecting the data. So like in our case, it'd be like taking your mobile device and collecting some data that might be useful for tracking, characterizing, and making predictions. So as much as like, I would say that there are fields that are quantitative and the answer is maybe immediate. There is also a push to take things where they're less quantitative and try to make them as quantitative as possible, and then say something about them. Like how can we, like if we wanted to track depression, there are these surveys that they use in the US PHQ-9. Are there like physiological equivalents that you might be able to track without having to query the person as much? Is something that I know that many research labs are working on.
Thank you.
Thank you. There's a question from NR1. Is that Ravi?
Yeah, Raju, thank you.
Yeah.
Yeah, thanks. Well, hi, Rajesh. Thanks a lot for your wonderful talk. I don't want to pretend I understood most of it. I was trying to keep track, but then I was sort of like going into the woods. And what I wanted to ask you was, I heard somewhere, I read in Japan, they're actually feeding in hundreds and thousands, if not millions of cancer slides. And letting the computer decide the diagnosis, particularly in prostate cancer, where they can then target radiotherapy to a very finite tissue.
Mm-hmm. Yeah, so this is happening. So there are both pros and cons of this. So the most exciting version of this I've seen is like when people are actually having a biopsy done during surgery. Like I saw an example of doctors here at Duke who are taking like biopsies during a brain surgery and they're waiting to do something. Maybe somebody here could tell me actually what you're waiting to do. And so they keep the patient open and they're looking for something, and normally they have a human read through it and it takes some time, and a computer can do it like much, much more quickly. And so like pathology slide reading is a great example of a case where like you can feed in a ton of examples and it's like they're giant images and they take a lot of time, and it's like a task that like a computer is built for. The downside that I'll say is that like if you take that model that is like trained on like Japan's data and you were to bring it here to New York City and you were to ask me like, would I believe that it would work? I would probably tell you, no, it's probably not going to work, because there are data sets that people have produced where like differences in like how they stain the slides for like different things actually provide some information. And as I said in my talk, that AI is just super helpful for identifying correlations in your data. And if these correlations are non-physiological, it will make use of them. So that would be like my negative on that.
Thank you.
Okay. Thank you, Rajesh. A question from Sivalingam, anesthetist.
Okay, thank you. Thank you, Shanmuraj, for organizing this excellent, exciting topic, fascinating speech by Rajesh. And the question to Rajesh, before asking the question, Like Ravi mentioned earlier on, I don't pretend also I understood everything. It was a very high powered. But a bit which was I understood was the ability of the AI to predict ejection fraction from the simple ECG. Now, that's very interesting. Good, very, really useful and handy. One of the things we get anesthetists, I was an anesthetist, asked about dealing with patients with a cardiovascular history, which is a common, either ischemic heart or hypertension. Is this patient fit for this complex surgery? And one of the things we want to know is how the cardiac muscles pumping ability. ECG only tells us the electrical activity of the heart, and we can ask for the echo, but echo is in British practice, it takes time and it needs to be organized, and also for emergency situations, we don't get it quickly enough. So this is very interesting. I'm really intrigued by the fact that ECG, electrical trace, can give an ability about prediction of the myocardial massive pump. And do you have collaboration of anesthesiologists, preoperative assessments with you?
I have no collaborations with anesthesiologists at this moment. I also know very little. I learned something just from that short thing you told me.
Okay, thank you. Well, that's a very good point, Siva, because doing a echo in NHS setting is a nightmare, especially for emergency, for acute emergency patients. If the ECG predicts ejection fraction, that will be nice. Okay, thank you. And then there's a question from Vadakalu Devaraja. Are you there? Vadakalu Devaraja, sorry, please unmute and ask your question. Devaraja?
Can you hear me? Can you hear me?
Yeah. Please, go ahead.
The normality is defined by the standard deviation of the top 2.5 and below 2.5. That's we define as normal. Doesn't mean what we define as abnormal is abnormal. What we like to define as 95% normal. If everybody belongs to the 95%, we call it as normal. If they don't, we call it as abnormal. It is all we made it. That's equally, so AI can only do what information we provide to it, and we expect what it needs to do it. It all depends on under control. So I believe AI cannot superlead our human brains.
That's a great question. So the way I thought about this is like, if you give me a bunch of data, how could you tell that COVID-19 was happening? Like COVID-19 is new, it doesn't exist. No human had labeled it. But like, if you're like sitting in like a hospital in China, and like, how do you know that there is something new that's happening? That's even like a first question. And like that in itself is like similar to like what you said, where like normal and abnormal as it's defined now is like human constructed. But like when we think about like, is there something new? Like, is there something different than what we've seen? Then like a computer might be able to answer a question like that. And the reason a computer will be able to answer a question like that is because like there'll be something different. Like if I think about like all my past knowledge, if I'm a doctor, I'm like, hey, I've seen these thousands of patients, and I know that there's like something different going on because I've never seen anything like this. The computer can make the same judgment. The real question is like, where does the information come from, and how do you build hypotheses to do it? So the way that people in AI are studying this right now is in physics, because physics is like, in some sense, by far simpler than medicine. And so like, can you learn the laws of physics if you give an agent access to an environment where they can like drop objects, they can throw objects, and can they learn like projectile motion and gravity? And, you know, in that sense, we believe the answer is yes. But in the sense of like medicine, like we don't even know how to simulate what's going on, and we can't necessarily build like prediction. And so when you say like, where does the knowledge come from? Then there's a bunch of human knowledge that exists that we don't know right now how to encode into a computer. And if we give a computer the opportunity to start from like whenever humans started from, to start trying to process that, would they be able to do it in a sample? Would it be able to do it in a sample efficient way? Is also unclear. And so I'd say that my comment is that for simple cases, yes. And in cases like physics, people are trying to answer the question that you're trying to do. Will that impact medicine in the near term? I would say no, because the knowledge that we have is more messy.
Thank you. Selvam, there's a stimulating question from Selvam. Please unmute and ask your question, Selvam.
Thanks. Thank you, Raja. It's a very simple thing. Stock market, they always say past performance is no guarantee of future performance. If that holds good in medicine, do we take AI with a pinch of salt?
Yeah. So there are two ways I can answer that. So the reason that you say in the stock market past performance doesn't relate to future performance from like a math standpoint is because the world is changing. So meaning that like there's some change in the world that has happened, like new technologies come into play or new kinds of like ways to communicate about like stock prices with the future market. And so the world has changed. So it's not the same. But then like if we think about human physiology on the time scale of like 100 years is not particularly changing. So if we have questions that are purely physiological based, then I would say like, no, you wouldn't be at the same risk. But then there are things that are like human physiology plus the environment. So if we think about, treating somebody's like tenure or like their survival time for myeloma would be a good example. If we built a model 10 years ago before like, new treatments came into play, you'd say the survival time is very, very small. But then the environment has changed. And now the survival times are longer, and that's because it's a function of human physiology and the actions that can be taken. So if you want to classify in your head where you have to be more worried and take it with a pinch of salt, I'd say when you're trying to make predictions that are also a function of the way that the treatment planning works, the way that human decisions are in function. If you're making something that's like this based on physiology, I would say no, because it's not really changing on that time scale.
Thank you.
Okay. Thank you. And there's a question from Shakti. Shakti, are you there? Please unmute and ask your question.
Yeah, thank you. A really fascinating talk. And thanks, Shanmugarajan sir, for organizing this.
Yeah.
A couple of observations. I think immediate reaction from people, maybe it can potentially replace their jobs and things like that, which I really can't see that happening in the immediate future. If any, maximizing and sweating these technologies could actually help save more lives. And, human mind can't hold everything at the same time to make decisions and critical points. So that was just an observation. But the question in my mind was, you mentioned right at the beginning, it's about taking various percepts and turning that into decision-making or actionable insights. But so far, the AI and machine learning appears to be only drawing from digital signals, right? There's no sort of analog percepts. And even if we have all the data in a digitized way, what kind of questions do you think AI and machine learning will never be able to solve?
Never is very difficult because like if you tell me that you could control the data collection process, like the AI has the ability to control what data it wants, then eventually it can cover like a giant amount of things. Like that might be unethical, especially in healthcare. But I'll give you an example of what the issues might be and like where we're seeing them. So like a self-driving car is something where like we really hoped would happen, and by many aspects is much simpler than like providing healthcare to providing care to a person's health. But the problem that you run into is that like if things are like okay, like you're in like the 99%, like it's like sunny, you're in California and it's in Arizona, it's like really great, it will work really well. But then in that like 1 to 2% where like things are like messy and are not like going on, it will fail disastrously. And that's because like, the reasoning systems aren't necessarily where they need to be. They're more like experience based. And so like, where does that reasoning come in? And like, what does that look like for a computer is like a question that we don't have an answer to right now. And so like, when we think about like things that are based on like experience and repeating, then I think a computer would have a great time doing it. If there are things that you need to reason about, you're like, well, if this, then this, but maybe this, and you want to translate like by a reason by analogy, like I've seen this before in a patient like this, and I want to move to that. Those kinds of things are much harder, and like people are working on it, but like how to do it, I'd say like a good test would be like once you see that self-driving car working, then you can have a good indication that like these kinds of things will come to clinical medicine soon.
That's really fascinating. That makes me just wonder whether AI means augmented intelligence.
Yeah. So the kind of impact right now, I think, would be exactly an augmented intelligence. Where
Thank you.
Yeah. Shakti, we don't want anybody else more intelligent than us. Yeah.
Human beings.
Yeah, human beings. Yeah. There's a question from Kirtini. Kirtini is a trainee radiologist.
And you can use stuff that's like off the shelf and relatively automated, but getting something to work that uses the clinical data along with the high dimensional data, like the electrocardiogram, is still quite difficult. And these are all math questions. And the second question you asked, I'd also say, is like a very, very important question. And like I have a student who's working on exactly a toy version of that question. And it's difficult in many ways because there's not if you have a data set that comes from only a specific kind of people, only collected in a specific spot, there's no notion by which a computer should know to ignore things that are related to that environment or things that are related to being from a Caucasian population. So who's providing you with that extra information to do something is something that a student of mine is working on, and under what assumptions can you do it? And this is a hot topic in machine learning. I think if you ask me again in like 3 years, we'll know like what's possible under what assumptions and where we can go with it.
Great, thank you.
Thank you. Ravi, do you have another question, Ravi?
Yeah, yes, please, Raju, very quickly. We've had hundreds and thousands of, patients suffering COVID, and there must be so much data all over the world. Can we use this data to predict long-term COVID conditions?
So now you've gotten to one of the questions where I'm like, you need some understanding of physiology, because like computers would really be good at doing things that they've seen already. So like, if you want to ask me what will happen 10 years from now for somebody that has COVID, it'll be very hard to say that because you need to be reductive. Like, how would a human make that same inference? A human would be reductive to something else that they know. They know that like this kind of scarring or like this kind of like clotting that happened can lead to these other things. And that kind of translation would be like great to be able to make some prediction. But if you just look at like all the COVID patients, there's not that information, that it doesn't exist, right? And so like whatever inference that you're making after like a 2-year time frame will be strictly extrapolative, and there's no way to check its correctness. So a computer could do it, but in the kinds of predictive models we're talking about, wouldn't work to do that, because you really want to be reductive and reduce to something else that has some of the similar features and extrapolate from that based on data that's already collected from it.
Thank you.
So we learn as COVID evolves around, yeah?
Yeah, as time progresses, we learn more things. We learn that vaccines are effective for a longer amount of time.
Yeah. Okay, thank you. And the next question is from Shakti. Is that a question or your statement? Do you want to talk?
No, sir. I was just making an observation, which I was just reminding myself that critical reason and patients better done by humans. Thank you.
Yeah, okay. Thanks. And Rangarajan has got a question. Rangarajan, please unmute yourself.
Thank you, Shanmuraj, for organizing this wonderful topic. Rajesh Ranganath's talk was very good, but we are all, on the home. It's a difficult topic for us, and he has handled very well. I mean, we are not that much into artificial intelligence, but it's a good coverage. I've got just a simple question. I mean, there is on most of the things with healthcare, it's cost effectiveness. Mm-hmm. So what's your thinking on that, please?
Well, on some of the things that we talked about where you're augmenting a person's capability, then we should be able to make costs lower in certain ways. Like if you can process more images as a radiologist, or if you can triage better in an emergency department, I think that we have one notion of cost reduction just from efficiency. On the other side, there could be a notion for making predictions into the future. So if we can reduce complications, or if we can, go query a patient, tell them to come in because their health has deteriorated, we might also reduce costs. So I think there's a large potential for cost reduction. That in terms of whoever builds these technologies might price them in a way that like just slightly under what the cost is. So it looks like it is cheaper, but then they're absorbing most of the value they create. But I think there's a large potential for it, because anytime we can be more accurate or more efficient, then we can both reduce the time that which clinicians need to spend, and also like reduce the number of things that need to be done to a patient.
Thank you.
Thank you. So you will keep all of us in jobs anyway, for the time being. Now, next question is from Ashok. Ashok from USA.
Rajesh, do you see artificial intelligence overtaking human race, like movie Matrix? The human race learns intelligence over a period of time, generations, whereas artificial intelligence learns very fast. At this time, AI depends on what we input. There's a limited port for it to understand. But in the future, things are not going to be hooked up to wires. It's going to be pulling from the space the information it needs. So AI can say, I don't need this guy's input. I can go out there and pull this out and say, this guy is stupid. I'm going to take over.
So you kind of answered my question already in the way that you phrased it. Like, the limitation right now is that we don't have like good agents that can go out into the wild and collect their own data. And so right now we rely on human inputs. So for things that we can automatically simulate, so like playing a game of chess or playing the game of Go, then yes, the computer would be like, well, I can do this much better than any human can. So to bridge the gap to get to like AI that might be able to do that, we'll need agents that can go out and collect data. It might be like simple data, like a baby might collect when they're like dropping or playing with like a device and figuring out how to control it. It might be much more complex data, like running a scientific experiment. There are places that are like doing both of those things, and bridging them together could be very exciting, where like, there are biology labs that like write code where the kinds of experiments that they run are determined by the data they collect during that experiment. And on the other side, there are people who are studying like, very simple, like fine motor control. Like, how do you learn how to like manipulate this device? If you give like a robot hand the same degrees of freedom and you let them like do it, and they can drop and make mistakes like a human baby would, can they learn how to do it? And so I think it's all about agents that can collect their own data.
Thank you. Are you happy, Ashok?
Oh, thank you. Thanks, Rajesh. Yeah.
Thank you. Yeah. Next question is from, Shakti is a statement, isn't it?
Indeed. Yeah. Thank you.
Okay. Do you want to say about your statement?
No, sir. I was just reflecting that we do collect so much data, and especially in the UK health service, it is pretty much linked to individuals and also over a period of time, unlike the US and the countries where it's very episodic and not really linked in time. And we don't seem to be using it very well. And even if we use it to beat people up for performance, or just mainly use it to save money. So I was just highlighting that I think we should, wherever it's appropriate, be brave and enter into this territory. I mean, this to catch up and to replace human intelligence. I mean, I don't think it'll ever happen personally, but even if it happens, it probably will happen a few centuries away. So I think we mustn't be afraid, but really embrace it and try and understand and explore wherever there is potential. It may be in small areas first, in very small scope, but we still do, even if we just take disease registers and connect that with patient records. And now we've got so many more developments happening, and all the records are digitized, and people have themselves the ability to put their own information in, and various, voice processing and various other things are coming on. So we should, including emotional health and well-being, we should be able to analyze words and understand meanings and try and use this for improve our patient care is what I was saying. But thank you again. It's a very stimulating discussion today. Thank you so much, MDMA as well.
Oh, thank you, Shakti. We already been reassured by Rajesh that artificial intelligence cannot surpass human intelligence. And now another reassurance from Shakti I'm very happy today. Next question is from Temuli. Temuli, are you there? I think it's just a statement. She says, yes, no one can replace human brain. Thank you, Temuli. Well, that comes to the end of the question. Very good. That's a very good talk and the time to thank everybody. My first thanks to Rajesh. Rajesh, you are from Nanjankood. If you travel from Coimbatore to Mysore on the road, your Nanjankood comes on the way in the hills. So very nice to hear from someone comes from Nanjankood. Thank you.
Glad to be here.
And it's very nice of you joining us today. And I know it's mostly laboratory oriented and data. Doctors need a bit more clinical pictures. But anyway, you have stimulated our brain. Now we are going to read about this, about the applications. Very good. And Rajesh was introduced by my classmate Ashok Kumar's son. Ashok is here. My next thanks goes to Ashok Kumar. Thank you. Is your son here in the audience?
No, he's not.
So Rajesh, he let you down. So now
I'll have to send him a text after.
Now you have reason to call him today.
Yeah.
Okay. Then I thank all the participants in the UK and from US for giving that time to join us today. And then the stimulating questions. I learned quite a bit today. And I thank you all the committee members who are present today. Some couldn't make it. First time I'm seeing some trainee doctors here. But thank you. Haven't got any more questions. I declare the meeting closed.